This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 90 for September 14th, 2023. We're calling this one Diversity, Equity, and Inclusion in Medicine. I want to welcome all of you to the program. We have another episode for you this week. It's one that applies to all healthcare providers, regardless of your role or your particular field in medicine. This one's for everybody, and it is a very important topic. You know, diversity, equity, and inclusion in medicine is important because underrepresented individuals often face challenges and barriers as they pursue a career in medicine. And it's important and helpful that we are all aware and have an understanding of these challenges and barriers so that we can help learners and our colleagues thrive in medicine. We also know that diversity and inclusion on healthcare teams improves healthcare disparities and improves patient outcomes. So how do we embrace diversity, equity, and inclusion at the medical school and institutional levels? How do we incorporate these important concepts into our practice of medicine? And how can we actively work to implement diversity and inclusion as we reimagine a healthcare system that takes equity seriously and strives to erase disparities in healthcare delivery and patient outcomes? It's an important conversation, and we have a fabulous guest to help us navigate the journey. Dr. Quinn Capers is Associate Dean of Faculty Engagement at the UT Southwestern Medical Center. Before we get to him, let's cover our usual quick reminders. Don't forget you can find PediaCast CME wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. Also, please consider leaving a review wherever you get your podcasts so that others who come along looking for free continuing medical education credit will know what to expect. Speaking of that credit, it is really easy to claim yours. Just listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. You do have to click on the materials link once you get to the page at Cloud CME. That's where you'll find the post-test. Also, we do offer credit to many pediatric professionals, including doctors, of course, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by all of those professional organizations, it's likely that we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of the episode matches your scope of practice. And again, this particular episode will match everybody's scope of practice. Complete details are available at PediaCastCME.org. Also, I want to remind you the information presented in every episode of our program is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get Dr. Quinn Capers settled into the studio, and then we will be back to explore the concepts of diversity, equity, and inclusion in medicine. It's coming up right after this. Dr. Quinn Capers is an interventional cardiologist and professor of internal medicine at UT Southwestern Medical Center in Dallas, Texas. He is a previous associate dean for admissions at The Ohio State University College of Medicine and is current associate dean of faculty engagement at UT Southwestern. Dr. Capers is a highly sought speaker and workshop moderator on implicit bias mitigation. And as a learner attending one of his life-changing implicit bias workshops, I can confirm that he is a talented and passionate teacher on this subject. He is here today to help us explore the importance of diversity, equity, and inclusion in medicine. But before we embark on that journey, let's offer a warm PediaCast welcome to Dr. Quinn Capers. Thank you so much for joining us today.
Thank you so much for having me. It's a real pleasure. Thank you.
Yeah. Well, thank you for taking time out of your busy schedule. I know you're visiting Nationwide Children's and gave grand rounds this morning, and just really appreciate you stopping by and chatting with us. I think a great place to start would be just if you could share your personal journey related to diversity, equity, and inclusion in medicine. How did this become an important topic for you?
It became important for me because I'm one of those doctors who never really considered doing anything else when I was a child. I wanted to be a doctor. I used to pray about it. That was my dream. And I'm very grateful, by the way, to be living my dream. It came true. I am a doctor. But I also was keenly aware of racial injustices in the country. And so always thought to myself that I also wanted to do something that was that would help racial understanding, that would help mitigate the impact of racism. And so it became a natural that let's see how we can combine these two, being a doctor and doing what you can to help with understanding and to mitigate racism and the impact of racism, et cetera. And so through the journey of becoming a doctor as a pre-med student, a medical student, resident fellow, I was always keenly aware of what at the time I didn't understand what to call it, but I came to know it as racial healthcare disparities, how people of different races, and not just races, sometimes gender, sometimes sexuality, sometimes and very often finances, people get different levels of care. And that always bothered me. And I kept my eyes open about it and began speaking about it as early as when I was a trainee in cardiology. And it simply became something that I researched and I studied with the goal of doing something to try to eliminate or reduce those healthcare disparities.
Yeah. And so as an interventional cardiologist, you have forged paths in terms of new research and techniques and different procedure modalities. But you've also really made an academic career out of diversity, equity, and inclusion. Have you found that the institutions that you've been a part of, were they open to that from the very beginning, or is that something that took work to show that this is really an important thing and valuable and can be academic work?
I've been at several academic institutions, and I can say that at each of them, Vanderbilt, The Ohio State University, UT Southwestern, have been open to the idea of exploring this and talking about it and leading discussions so that we can do better. Obviously, there are always people in your bubble who truly agree with you. And then there will be some who are outside of the bubble that might take more convincing. But I'd say institution-wide, those institutions, and I can't leave out where I trained, Emory University, those institutions have all been welcoming to the idea of discussing healthcare disparities and trying to eliminate or reduce them.
Yeah. And I would hope that that is true for many academic institutions across the country. And I would just encourage listeners, if this is not something, if you're hearing something new today that is not really within the culture of your organization, is to seek it out. I mean, maybe it's there and you're just not aware of it, or maybe there really does need to be a conversation that gets started. And this hopefully is a little bit of a foundation that you can use today with this episode. So I think another great place to start is just to identify the key challenges and barriers that underrepresented individuals face when they're pursuing a career in medicine. I mean, what are some of the obstacles that others may not really be aware of?
One of the biggest obstacles is a lack of role models. If you think about children and even adolescents, and here I'm talking to a pediatrician about children, adolescents, and people growing up, as your mind is forming, you begin to get ideas about the world of what you can do, what you can achieve, usually by seeing someone that you have something in common with achieving that thing. And so only 5% of practicing physicians are African American. Only about 7% are Hispanic. Significantly less than 50% are women. We don't know the numbers for LGBTQ+ because we don't collect them, because there's some stigma associated with that community. And the numbers for those from indigenous communities, Native Americans, Native Alaskans, et cetera, are hover around 1%. And so one of the biggest challenges for children in those communities growing up to want to be a doctor is seeing someone who looks like them, who has achieved that goal of becoming a doctor.
Yeah. Yeah. And so representation and role modeling is so important. What are some other barriers that folks?
Some of them relate to the structural biases in our educational system. So one systemic racism pillar that continues to impact diversity in the professions is segregated housing. And so with redlining and with other restrictive covenants in neighborhoods, there was a whole generation of Americans who were told where they could live, where they were allowed to live. And those who came from underrepresented backgrounds were forced to live in places with overcrowded schools, underfunded schools, under-resourced schools, schools that did not get the same level of financial investment. And so then there's a whole generation of children who went to those schools, and maybe certain skills like doing your very best on a standardized test or mathematical competence is lower. However, if you were to look at other things like resilience and persistence and doing a lot with a little, children from those backgrounds really excel. But in the academy, college admissions committees, medical school admissions committees, residency and fellowship selection committees tend to still traditionally look at who scored the highest on the test and who did these traditional things. But some of these traditional things really put, because of societal racism, people from certain backgrounds at a disadvantage.
Yeah, absolutely. In your Grand Rounds presentation this morning, you had mentioned that what standardized exam scores really represent is how much of an income a person came from, not necessarily what they can do in the future. And I think that is so important because it's so easy just to look at a number and make a decision about someone without really looking at the big picture and understanding that low score may come because they didn't have the opportunities that they needed to really thrive.
Absolutely. And I want to say here that because I want our listeners to be clear that I think standardized testing is a good thing. I think it has a place. If I were a president of or the dean of an architecture school and there were some test that you could have high school students take that was validated and showed their aptitude in the field of architecture, I would use it. I would use that test. So I'm not against using standardized tests to help in the admissions process. But clearly, in our educational system for so long, we overemphasize them, and we actually use them to define a very loaded word, qualified. Like if you scored an 85% on the test and I scored an 80% on the test, that means you're more qualified. And really, the score on the test should be only one of about 6 things that you use to say whether or not someone is qualified.
Yeah, because qualified just means you have a foundation that is strong enough to build a structure on. And it doesn't really matter. I mean, there's not necessarily degrees of strength of what that building can end up being. Maybe I'm trying to oversimplify this a little bit.
No, it's potential.
But yes. Mm-hmm. And so as long as you get that minimum score, but if someone, got a really high score, they also have a strong structure. And there's so many things that go into building a medical career. I mean, empathy, communication skills. I mean, all of that is just as important as basic science knowledge. And that's not really tested on a standardized exam.
Absolutely. Yep.
Yeah. So really a holistic approach to admissions and not just basing it solely on a standardized exam score would be one of the ways that we can mitigate the challenges and barriers that underrepresented folks have that they face. What are some other ways that we can address the challenges and the barriers?
One very important thing, and we talked about this morning during our grand rounds, is reaching back to children. I mean, it's a long haul. I mean, you know it. You've lived it. It's a long haul to becoming a doctor. You got to do well enough in high school to get into a good college. You got to do well enough in college to get into medical school. You got to do well enough in medical school to get a good residency. So it's a long haul and a lot of delayed gratification. But the encouragement and the inspiration to stick to it, that long haul, is something that we need to instill that in younger communities, especially communities from people who are underrepresented in the medical profession. So we need to reach back to children. There's an interesting cohort study that I think was done out of Vanderbilt University where they actually followed 8th graders for 4 years until the 12th grade. And they asked in this national sample of at least 20,000 children, they asked 8th graders what we like to ask children. What do you want to be when you grow up? And it turns out the proportion of Black, white, and Hispanic children who say, I want to go to medical school, or I want to be a doctor or a lawyer or some profession, is about the same in those groups. But as they followed them through the years, by the 12th grade, it was 2 groups in particular that were much more likely to drop that aspiration, and that was Black boys and Hispanic girls. So something happens between the 8th grade and 12th grade that makes Black boys and Hispanic girls think that being a lawyer, being a doctor, going to college and grad school is no longer an option for me. It's no longer realistic.
Yeah.
And so that's where we need to be attacking.
Yeah.
We need to be down at those levels and maybe even earlier, letting them know, no, you can do this. And in fact, I think you're going to be a very good doctor.
Yeah. It would be interesting, I think, then to look at that group of folks and see who had positive role models in their life who looked like them and then went on to be successful versus those who did not. I think that would make a great study.
I agree.
That would, to show that this is really important and makes a difference.
Yes. Yes.
Yeah.
So exposure and then active recruitment. Go to where people are who come from groups. We know the groups that are underrepresented in medicine. We know where they can be found. So our recruiting has to be focused and it has to be active. I once did a talk where I polled the audience and I was speaking to a group of program directors, residency program directors, and this was especially of internal medicine. And we asked them how many of them, first question was very simple. How many of you recruit for your residency program? You could imagine 100%, everybody recruits. Then the next question was, what do you do to recruit? And, I say it kind of humorously now, but it really shows the depth of the problem that 85% of them, their answer to what they do to recruit is they keep their website current. That's how they recruit.
Yeah.
That's a very passive way.
Yeah.
That's a very passive way to recruit. Now, yes, you got to keep your website current, but you got to do something. If you need more women in your surgery residency program, if you've never had a person of color in your cardiology fellowship, keeping your website current is not enough. You have to go out there and actively recruit.
Yeah, that's so important. Here at Nationwide Children's Hospital, I'm just going to put in a quick plug. We do have a medical interest group that goes into the inner city schools in Columbus and finds the kids that are interested, and they have programming and they come and they hear talks from pediatricians and pediatric surgeons and get to experience a day in the life. And I think that that's at least one little step that other places can hopefully embrace and do something similar.
That is awesome.
Yeah.
Awesome.
And then once we have these positive role models in place and we're encouraging kids, and then they have success and they get into medical school, they get into a residency, but that's not really the end of it because there's a lot of rungs of a ladder to climb, especially in academic medicine.
Yes.
And so I would think that the role of a mentor as you're training early in your career is going to be also very important for underrepresented folks.
I couldn't agree more. Yep. But what I'll say here, and that's really important, and I want people to be sure they hear me, while it is positive, very positive, if your mentor shares your background. So I'm a Black male from the west side of Dayton, Ohio. It would be nice if I had a mentor who was a Black male from the west side of Dayton, Ohio, but it doesn't have to be. Anyone with a heart, anyone who wants to help, anyone who wants to reach back can be an outstanding mentor. So I think that's important and worth stating. And so you're absolutely right. The mentorship, there are a lot of, and I'll say what you said, but I'll say it a different way. There are a lot of gates from kindergarten to medical school. And there are a lot of gatekeepers at those gates. And so there are people that you have to impress the right way. And having a mentor to help you navigate that, especially if you're first generation, the first in your family to go to college or medical school, critically important.
Yeah, absolutely. I also want to mention implicit bias training. And while our conversation today is not focused on that, I think it's an important thing. And I know for me as a white cisgender male, that workshop that you facilitated really made a big difference in my life in terms of just opening up and seeing like how I grew up, what thoughts go into my brain that I don't necessarily even want to be there, and being aware of those things and then trying to change thinking to really be the person I want to be. And so I just want to thank you for that. Can you?
You're very welcome.
Yeah. Can you just speak to the importance of implicit bias understandings within the medical community, both in community medicine and academic medicine?
Absolutely. First of all, thank you so very much for your kind comments. I really, really do appreciate them. Implicit bias, this concept that we all have unconscious, outside of our conscious awareness or conscious control, associations that we make about people based on, what we've been seeing all of our lives is so critically important and has been shown. Unconscious associations have been shown, for instance, to sway judges when they're sentencing in the criminal justice system. And this is why sometimes you get people of different races who commit the exact same crime get different sentences, sometimes a severe disparity. It can sway jurors. It can sway doctors in the care that they give. It can sway police officers and how they approach someone that they want to ask questions. And so these unconscious associations come from the images that we see our entire lives. And our brain is really trying to help us out. It's trying to help us take a shortcut by coupling certain things. One of my favorite commercials on this, and what I try to do sometimes in my implicit bias workshops is capture a little video clip for humorous purposes, but makes the point, I believe the purpose of the commercial is for a financial management firm. And it starts with a couple, it's a married couple, and they have their nest egg, and they're going to entrust it to this gentleman on the other side of the desk. And he is a white male in a suit. And they're essentially saying they're pushing their portfolio towards saying, please manage all of our money for us. And he pauses and he says, I'd like to, but I'm just a DJ. And then he gets up and starts dancing around. And then it shows him in his real natural habitat with long hair, a beard, piercings, and dressed like a DJ. But for this portion, he was clean shaven and in a suit. And even though it's not the point of the commercial, and they might not appreciate me using it this way, it makes the point that one of our unconscious associations in this country is that a white man in a suit is smart, he's compassionate, and he's here to help you, and he's trustworthy. Well, I know a lot of white men in suits who are all of those things, mm-hmm. but the images that have bombarded me make me give the benefit of the doubt when I see a white man in a suit that he's competent, he's smart, and he's here to help me. That's an example of an unconscious association. But the reason I have that is because I've been bombarded by those images. By the same token, if very often when I see a young black male in a hoodie, it's on the 6 o'clock evening news and he's been taken away in handcuffs, or it's showing him in a fight or some altercation. If that's how he's often presented to me, then my unconscious mind will associate a young black man in a hoodie with crime. And these unconscious associations have been shown to affect how we interact with people.
Yeah.
Whether or not you look somebody in the eye and say, hello, good morning, how are you today? Can be influenced by these unconscious associations.
Yeah. And those happen very early in childhood, don't they? So you can ask young kids, like, which picture is more likely to be the doctor and which picture is more likely to end up in handcuffs. And even underrepresented kids will pick just like others do, because those experiences and biases are still formed regardless of your race.
That's right. And actually, and with the advent of social media and the fact that our children at very young ages have iPhones or access to iPhones, and so they're seeing these images from all over, you're right, these unconscious associations can set in very quickly. One heartbreaking psychological test that I think we talked about in the session that I did with you was the doll test, where you show black and white children images of black and white baby dolls, and you ask them questions about the dolls. And one particularly heartbreaking clip that I would show in my workshops would be a black little girl looking at a white and black doll, and she's asked, which one is the bad child? And she points to the black. which one is the ugly child? And she points to the black doll. And then the investigator asks, and which one looks more like you? Which one is more like you? And she points to the black child. So here she is, a black child, and she associates black skin with bad behavior and ugly. And that is because of what, she wasn't born thinking that.
Right.
But this is what society has been telling her. And think about how that is going to have her interact with people as she grows up. So unconscious associations can be very powerful. And the purpose of those workshops and training in this area is because we tend to think that if someone makes a decision that puts people of a certain race at a disadvantage, then they are a bad person. They are an explicit racist. People who actually are very egalitarian in their heart can be making decisions that put people of color at a disadvantage, or people of any particular group at a disadvantage because of these unconscious associations. So a very, very important topic.
Yeah. And I would say if you're a medical provider listening to this and you have not had the benefit of a implicit bias workshop, please seek it out. I mean, this really can be life-changing, and really just being aware of these things can make such a difference in your life moving forward, not only professionally, but personally too. So I'll put in a big plug to participate in one of those activities. I'm going to pivot here a little bit and talk about diversity in healthcare teams and how that is associated with patient outcomes. So not only is it important to give the underrepresented folks the opportunity to become healthcare providers, we do know that when we have diversity in healthcare teams, we actually have better care. How does that work?
It's really interesting. Some of it might be because of lower implicit negative associations when you're dealing with somebody who comes from your group. But many research studies have shown, if we start with communication, that we are all more comfortable communicating with somebody who reminds us of our uncle or our niece or our brother or our community. And so you might share some things that you wouldn't ordinarily. So it shows that patients are more likely to open up and share more if a doctor shares their background. The other side of that is the doctor tends to spend more time. And this one is really can be an indictment against our healthcare system. But doctors in one particular study, and this was with cancer doctors, spend more time with patients who share their background than they do with patients who share a different background. So now you're talking about communication and the patient-doctor relationship, which is so important. Patients of minority backgrounds in survey studies have shown that they feel more like this doctor is invested in me if that doctor shares their background. So culture is important. Speech patterns, speech, language is certainly very important. So that's one thing that's very important, but it goes beyond just improved communication. That improved communication also appears to be associated with actual outcomes. Yeah. So doctors are more likely to, if they feel like they understand the patient and the patient's motivations, more likely to recommend certain therapies for those patients. Those patients are more likely to comply with those therapies. And this, recent studies have shown, can translate into, or at least be associated with, better clinical outcomes, including mortality.
Yeah. And I think a term that we'd have to inject into that at some point is health literacy, just in terms of that communication helps folks understand, you have empathy for the patient's background and situation and obstacles and barriers. And because of that, you are taking the time needed to teach in language that the patient can understand, the disease process, why this particular medicine is important. And then as that understanding improves, then you have increased compliance and trust in that provider. And so folks, do what you ask them to do and they get better. And so it really makes sense.
Yes, it really does. And, an example I like to use that I think is a good example is one of our wonderful new technologies in interventional cardiology is the ability to replace the aortic valve, the main valve in the heart, with a catheter-based approach. So without open heart surgery. So we can repair your heart valve without having to open your chest. And that's a tremendous advance in our specialty. And in some of my workshops, I tell people to imagine that you're trying to consent an elderly woman for this procedure. So you tell her about the procedure, you tell her about the risks and the benefits, and she says, no, thank you. But without this, she ultimately is going to die of her diseased aortic valve. It is possible. and the data seems to imply if this person is from a background different from you and you don't feel like you truly understand her, then you will try once and she will say no, and you will leave the room saying, I have done my job. I told her the risks and the benefits. She said no, she's a patient. She can make her own mind up. But if she reminds you of your grandma, you stay in the room a little bit longer. And before you leave the hospital for the day, you might circle back to her room one more time and say, okay, have you had a chance to think about this? Do you have any other questions? I mean, you're a little more persistent. Now, the reason that this is an important one is because when you just mention it, talk about risks and benefits, and they say no, this allows many doctors to say, what are you talking about? I'm not biased. I did my job. My job was to explain the risks and benefits. She said no, she's an adult. We can't force her to do anything. What they're not seeing is that somebody from your community, you might have spent a little longer. You might have said, okay, the first way I explained it to you didn't get the point across. Let me try a second way. Let me try a third way. And so this I think is translating into real hard clinical outcomes.
Yeah. Yeah. And I'm glad you told that story, because it really leads us into the next point that I wanted to bring up. And that is the way that our healthcare system works. There is no guarantee whatsoever that you're going to get a doctor who reminds them of their grandmother. And
Yes.
so that then brings into light this concept of cultural competency. So what exactly is that, and how can we as physicians and other medical providers use cultural competency to make a difference in patient outcomes?
So cultural competency really relates to and is defined as your ability to be aware of different cultures, how they communicate, what value they put on different things, all the things that go along with culture. And now it might be difficult for you to, nobody's saying that you need to learn 10 languages and learn 10 different cultures. And so I really like to use the term cultural humility as well. And that is I don't speak the Russian language, and I may not be very knowledgeable about Russian culture. I respect that this is a culture that has value, and I'm going to respect this culture, and I'm going to try to make sure I include that in my recommendations for the patient based on what the patient and their family is telling me. So that cultural competency is so important. And a lot of that comes from us being in a diverse milieu. And this is why research has shown that doctors who graduated from diverse medical schools are more comfortable treating diverse patients than doctors who graduated from medical schools that don't have a diverse student body. And that's because we learn from each other. So imagine, now I'm old school, and you can tell because I'm going to talk about a gross anatomy lab where we had a cadaver and 4 physicians in training around that cadaver for an entire semester. In most places, it's not taught that way anymore. It's more technologically advanced. But if in that group of 4, I have an Asian student and a Black student and a white student and a student of another background, all semester long, we're working together. So we're learning to respect one another. And I see that my Asian and my white and any other race, that they are compassionate, that they're funny, that they're humorous, that they're smart, that they're ethical, that they're moral. That lasts with me when I go out and treat patients of that background.
Yeah.
And so training in a diverse milieu is, or working in a diverse milieu is one of the best ways to enhance all of our cultural competencies.
And it would seem to follow then that that's also important for LGBTQ plus folks.
Absolutely.
That you could also put one of them in that group, and it would make a big difference.
Or someone with a physical or motor disability.
Yeah.
Yes. Mm-hmm.
Yeah. Absolutely. So what then can we do as healthcare organizations, institutions, and colleges and schools of medicine to facilitate that happening, and particularly if there's not a diverse student body?
So if there isn't a diverse student body, then curriculum leaders and medical education leaders need to move heaven and earth to get their students to work in diverse populations. So that might mean rotating in different hospitals where they are exposed to patients of different populations, veterans, people from socioeconomically disadvantaged circumstances. So if you don't have it in your student body, you can get your students to clinics. Maybe there's an East Asian free clinic that you can have your students rotate through.
Yeah.
It is worth seeking out those opportunities, because for that student or that resident or that fellow who has those interactions, it will help all of their future patients.
Yeah, absolutely. And I think that for schools who do not have as diverse of a student body, this is really a wake-up call that you need a diverse student body for folks to become physicians who thrive and care about all people. And so if you don't have one, please try to get one. And if you are a student looking at a place to train, ask about the diversity. You should be aware of the numbers. And this is an important thing, because if you want to be a physician who can relate and make a difference in all people's lives, this is a diverse place to train would be something that you would want to seek out. And yet, despite the fact that all of that seems to make sense, there is a movement against diversity, equity, and inclusion as official policies at state institutions, which really would just roll all of that back. Would you agree with that? And what can we do to stop that?
Absolutely, I agree with that. And not only the state-by-state march of legislative pushback against diversity, equity, inclusion, I'll call it, but also you got the United States Supreme Court ruling that the considering race in higher education admissions is not constitutional and should no longer be done. So that has been taken away from us. And so this represents a real challenge. However, there are still opportunities to try to have an inclusive and diverse workforce in medicine. And what we need to do now is continue what we're doing, but we need to change it from considering race to considering what is this doctor going to do based on what they have been doing. What is this doctor going to do based on what we can predict from where they're from, the community that they are from? We also know that before the Supreme Court decision, there were already 9 states that had state-initiated ballots that outlawed the use of race in higher education admissions. California is one. The state of Washington is one. The state of Michigan is one. There are others. But in those states, they have still managed to have some diversity in their medical schools. Particularly, I'm going to give a shout out to my friends at University of California, Davis, a true exemplar of having a very diverse student body in a state where considering race in admissions is not allowed and not legal. But there are ways to do holistic review and to say, we are wanting to recruit doctors who will help us take care of all the diverse communities. And you can do that without considering race and still come up with a diverse student body.
Not easy though, right?
Not easy, and not exactly the same.
Yeah.
But we have to all be registered to vote and keep doing what we can at the polls. And until things change again, which I'm hopeful they will, then we have to be strategic in how we work to have inclusive excellence.
Yeah, absolutely. That totally makes sense. I want to take another pivot and talk just a bit about medical research and clinical trials. And it is important to include members of underrepresented groups in that. Why? Well, first, why is that an important thing?
It's a very important thing for a couple of reasons. One is because participating in a clinical research trial can actually have significant benefits for the patient. And in some cases, it can be life-saving. We tend to think of that more easily when it comes to cancer, but let's take that as an example. If I have a cancer that is resistant to the current therapies, and there's a clinical trial of a new combination of chemotherapy drugs, my being entered in that clinical trial may actually save my life. And so when we have clinical trials that still are largely male, largely white, and we are leaving out diverse populations, it hurts for that reason. Another reason is because if it is a new treatment, a new drug, a new device, a new procedure, if we haven't had a representative population in the study that showed it was effective, then we might be missing important beneficial effects or important adverse effects in this drug. And then when the FDA approves it based on that non-diverse study, we could actually be hurting certain populations. The best example of this I can think of is with an antiplatelet, a blood thinner drug called clopidogrel that actually requires activation to its active metabolite by a liver in the enzyme. And it turns out that the genetics of this enzyme liver is such that people of Native Hawaiian descent are lacking that particular enzyme. And so they don't activate this blood thinner as well. Well, this is a blood thinner that we use when we put a stent in someone's coronary artery. And you've got to be on blood thinner so that you don't get a blood clot on that stent, which can cause a heart attack. Well, it turns out the studies were not at all diverse. The FDA approved this blood thinner, and then there was a rash of heart attacks in East Asian, but particularly those of Native Hawaiian descent. And in fact, and something that's really unusual, the state of Hawaii is suing the manufacturer of that company for a multi-million-dollar suit, and they were at least initially awarded that suit. I would say when it comes to having diverse clinical trials, when you leave people out, you are depriving them of the benefit of being in a trial. And when you don't have a diverse trial and that new treatment is approved, there are some things that we could be missing. So we need to have training to be clinical trialists and clinical research coordinators and entities that perform clinical research on how to reach out to diverse and minority communities to make sure that that we are including diverse individuals in these trials.
Yeah, and I think you've made a great point for the importance of having a diverse population within a research project or a clinical trial. There is also some difficulty in recruiting underrepresented folks because they have been abused in the past, and it may not be things that they know about from history, like, studying it or reading about it, but even stories within families can make it difficult. And so how can researchers and those who recruit folks into clinical trials be sensitive to that and provide some reassurance maybe?
I'm so glad that you brought that up because that is so very important. Communities of color and those of any color who come from disadvantaged backgrounds have been historically mistreated by the medical system, and particularly those doing research with just heartbreaking stories of people being used as quote unquote guinea pigs. And in fact, you still hear that often in minority communities. If someone mentions a study, you often will hear an older a person of color say, they're not using me as a guinea pig because of these stories that they've heard. And it's not only that, we can't just blame it on history. They're using their own modern day experiences in the healthcare system. So what can we do when we want to reach out to minority communities? Well, number one, we can be educated about some of those past atrocities, but we can also approach them in a way that is important for their culture. And a very important study not too long ago did a focus group of, I think this was Black patients at Grady Hospital in Atlanta, Georgia. And it was simply asking them how they feel about research and particularly participating in a research study. And what came out of that was something that was really important and I think needs more attention. One is their consensus was they understand that research has a positive impact on society. And they're not against being in a research study, but they want more time with the consent form. They want to be able to take it home and show it to people that they trust, like their pastor or their family doctor or their nephew that went to college. And they want to see more people like them asking them for their consent because of the trust factor. Yeah. So we can learn from research that's out there about the best ways to reach out to the community. But one thing that comes up again and again is people who come from a background that has traditionally been mistreated by the medical profession. They're not against participating in a research study, but they need more time. So this rush that we have sometimes, and a patient that we want to participate in a cath lab research trial, they're in the prep holding area, and we come to them with the consent form. Oh, this is a study where we're trying stent A versus stent B. Can you please read through this and sign this? That's, for many people, that's too fast. That's too much. Let me take this home. Let me sleep with it. Let me think about it. And so we have to make adjustments.
Yeah, absolutely. And there are situations where it really is urgent and an emergency, and this really needs to be done. And in those situations, like if you don't have time to really think about it, maybe those folks shouldn't be enrolled in the first place.
Yes.
Because if it's urgent, that's just one of those things you got to give people a chance to think about it and learn about it before they accept it.
That's correct. And not to give up on those emergency studies, but that's where we need to train more a diverse cadre of clinical investigators. So a woman may be more likely to consent to an emergency procedure if the doctor is a woman. A Black person may be more likely to consent to emergency procedure that is a research study if the person sitting next to their bedside talking to them is somebody that comes from their community.
Yeah. And you could also argue that there's a role for a retrospective look. So if you're going to enroll someone in a study and do stent A versus stent B and then follow them forward, that's one thing. But there's also the opportunity in an emergency situation. Someone got A because stent A, because the interventional cardiologist likes that stent better, and someone else got B. And then you could go down the road a bit and look back and see, who had different outcomes. And so, I mean, there's still a way to include them in research that just may be a different type of project than the prospective
trial.
Yeah,
absolutely.
Yep. All right. Well, one final thing. This has been a wonderful conversation,
and
I feel like
I've enjoyed this. Yeah, man, we're rolling. Yep.
I feel like we could continue it for a long, long time. You'd mentioned that we can vote in order to make a difference. We can also lobby our legislators. What is the role of physicians in terms of advocating for diversity, equity, and inclusion in medicine, in terms of folks who have already been elected and are in the legislature? Have you done any lobbying or support of that in the state capitals?
Individually. I've had individual conversations with legislators, and I think you can get so far with individual one-on-one meetings. I think, though, people who are in elected positions, they tend to think about the most votes. Where do the most votes come from? And this is where I think a role for our organizations. So a group like the American College of Cardiology or the American Academy of Pediatrics that represents thousands, if not millions, of doctors, having a lobbying arm that most of them have, but they've been focused on, well, let me just speak about cardiology organizations. They tend to be focused more on, let's keep the reimbursement up. Let's not keep dropping the reimbursement for the procedures that we do. And that's important. But I would like to see more of the lobbying arms of our medical organizations lobbying for the importance of legislation that won't hamper our ability to recruit a diverse physician workforce.
Yeah. And that sort of training, actually, for we have a lot of pediatric residents who listen to this podcast, seek out an advocacy elective. And, if this is something that is passionate to you, and I hope it is, then that may give you some practice and some experience in terms of lobbying legislators. And so advocacy electives are good things.
That is awesome, because that's not a skill that is ordinarily a part of a residency training program. Yeah. And it's something that you have to be, or that you should be trained in the best way to do it.
And I'll put another plug in for Nationwide Children's Hospital that we do have that sort of elective experience for our residents. So
I wish I would have had that when I was a resident. So kudos.
Yes, absolutely. Well, we really appreciate you stopping by today. We're going to have a ton of links in the show notes over at PediaCastCME.org. So just take this as the beginning and then dive deep into some of these resources. So just some examples. We have from the American Association of Medical Colleges a diversity and inclusion toolkit, from the American Academy of Pediatrics, eliminating race-based medicine and the impact of racism on child and adolescent health, from the American Medical Association, their Center for Health Equity, the American Psychological Association, they have guidelines for psychological practice for people with low income and economic marginalization that I think is helpful. We have a couple links from the Centers for Disease Control and Prevention, Advancing Health Equity and Preventing Chronic Disease, also Health Disparities and Strategies reports. One from JAMA, updated guidance on the reporting of race and ethnicity in medical and science journals. From the National Institutes of Health, NIH Scientific Workforce Diversity Toolkit. And we have some things from the Society for Adolescent Health and Medicine as well. So ton of resources. Please check those out, dive in, learn more about this, become passionate, because we want to care for all people every day. All right. So Dr. Quinn Capers, Associate Dean of Faculty Engagement from UT Southwestern Medical Center. Thank you once again so much for visiting with us today.
Thank you so much for the invitation.
are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thank you once again to our guest, Dr. Quinn Capers, Associate Dean of Faculty Engagement at UT Southwestern Medical Center. Don't forget, you can find us wherever podcasts are found or in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You'll find our entire archive of past programs there, along with our show notes, CME information, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Instagram, Threads, LinkedIn, and simply search for PediaCast in any of those locations and you'll be able to find us. So you have listened to the podcast. Now be sure to claim your free Category 1 continuing medical education. It's a really easy thing to do. Simply head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. Again, you do have to click on the Materials tab in Cloud CME to find the post-test. It's really easy, and again, we offer credit to not just doctors, but nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Complete details are available at PediaCastCME.org. Also, don't forget about our evidence-based podcast for moms and dads, plain PediaCast without the CME. Lots of pediatricians and other providers also tune in as we cover pediatric news, answer listener questions, and interview pediatric and parenting experts. Shows are available at the landing site for that show, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.